dogs and its relationship with mobility. We'll look at some of the factors as they relate to HIV/AIDS, because it's a best example of seeing how a virus can actually be globally spread, if you like, but also how transmission modes and rates do vary very much between countries, and it also varies in terms of their resources, in terms of availability of drugs and treatment. And I'll look specifically at Asia, and I want to look at Indonesia as a country where this has become a problem. And right near the end I'll talk about Australian context very briefly, because I got asked in another course, but Australia surely doesn't have any HIV/AIDS cases. So I put it in on your lecture as well, just to show you, yes, it does happen. It is happening, sorry. Really, we're back to this sort of relationship. Migration, we really looked at socioeconomic development and its relationship, but clearly environmental impact is important, which I'll look at next week, and also health and well-being clearly linked to the health of migrants, or migrant health, and compared to non-migrant health. But really today I'm actually trying to say there's impacts in terms of the movement of people, particularly migrants, and particularly circular migrants, and some of their impacts that can happen, are happening and has happened. So clearly mobility can be an agent for spreading disease. It can be internal movement and international movement. Internal movement, we tend to look at patterns of rural-urban migration, but clearly there's big implications for countries in terms of the spread of disease. And clearly, like we talked about security and migration in Australia on Tuesday, there's a health element to that in terms of screening people coming into the country for certain conditions and certain health aspects. If you're applying for permanent migration, for example, you'll be screened, and clearly if you've got TB or HIV/AIDS, or if you've got health problems with your children as well, that can stop family migration as well. So health screening in Australia with visas on all types of migrants coming in clearly has an impact on some of the domains in terms of security and health. And there are differences in health of migrants and non-migrants, which I want to actually have a look at. There's implications for health provision, particularly in countries where migrants or foreigners, particularly if they're undocumented or illegal, may actually be very much at risk because they don't have access similar to people who are residents in those populations. And obviously there's complex linkages between socioeconomic change and environmental change. All these things in that diagram actually have feedback loops as well. So when we're looking at just population movement, it's more than just numerical effects. We like to look at the causes of those socioeconomic changes, underlying patterns of movement, and they link with in-migrants in the destination and also in the origin. So more and more we look at the links between those two parts in terms of where they're coming from and where the host country is looking at them. And we should know by now that migration is always selective. Selective usually by age, younger age people, families are more likely to move than the older groups. Can be selective of males and females, as we were talking about yesterday, and also clearly by education levels, types of occupations, types of skills, and unskilled. Whilst Australia favours skilled migration, there's many parts of the world where migration loops are really being stimulated by the need or the demand for unskilled or low-skilled labour, like our overseas contract workers we're talking about, and other groups as well. So it's selective, but it's selective particularly to demands, whether it's female-dominated work that's required or is demanding labour, or if it's highly skilled labour, like Australia tends to want to demand. So factors influencing the health in terms of age, sex, education, skill levels, and also, in a way, cultural levels will also influence. Culture meaning by country, by birthplace as well. Health problems resulting from migration, particularly amongst refugees who might have experienced very poor conditions for long term and not particularly been treated or inoculated for diseases and whatever. And so sometimes if it's a high refugee settlement population coming in, they can have very different health characteristics than a local resident population. That could also be related to mental health, anxiety issues, depression, and just lack of exposure to what is experienced in a new environment. That new context at destination is generally moving to a different country for refugees, generally urban situations, but they might find themselves alienated at the destination. So that increases some of their long-term anxiety or depression or mental health. There's vulnerability factors, and we touched on some of these yesterday, but some groups, particularly women, might be very vulnerable in certain situations, and that migration and vulnerability might put huge stress on not only their health status, but clearly that could relate to whether they're particularly working in the sex industry or being abused in some way. Clearly that will relate overall to their mental stability, but also their general health. And for example, if maids get pregnant or some other terrible disease like pregnancy, they'll get deported. In other words, they're not needed or wanted, and that. And again, we were getting into some of that yesterday on terms of the trafficking. It's similar, those who become dancers, entertainers, health workers, particularly in places like Korea. They suddenly develop an STD or HIV in particular, they can be deported without really acquiring the right treatment or anything else. So there's a lot of vulnerability factors there. It may be that they just can't access a health service or provision because they're in China, they've moved to a city even without hukou. If they don't have hukou, they don't get health coverage. In Vietnam, Indonesia, it can be the same. They might not actually have access to a health service in a major area they've moved to, or even know about it. So that limited access to health services sometimes includes education programs such as those to counter obviously HIV, AIDS, and also STDs, sexually transmitted diseases generally. Generally they don't get, unless they really are exposed to some program, they often really don't know some of the risks in particular and some of what is being proposed for them to practice. When we're defining population mobility, remember, well, in some contexts I like to talk about population mobility, other contexts I'll talk about migration. And migration really is that permanent relocation and settlement, and but non-permanent migrants are often those most at risk because they do move around. They're usually less settled, less stable, and often more likely to be young populations and not necessarily as couples, so they're looking for other sort of activities, if you like, or lifestyle problems. Migration, we've been talking about circulation, So migration is really that traditional model of settlement, temporary or non-permanent, is much more likely to lead to circulation. They may go back to a home country, they may go to another country, or they may move between cities in Australia or wherever, but it's usually entails some sort of circulatory movement, more so than a permanent settlement move. It may ultimately lead to a permanent settlement somewhere, but there'll be years where that might be far more flexible and mobile. That's why sometimes we like to talk about personal mobility or population mobility, because we're sort of indicating that we've got this circulation. So that includes international, regional as well as local movements. Most of the regional movement within countries is from rural to urban areas or between urban areas, but clearly that is the bulk of the movement. What we're really looking at in this course is creaming off the top in terms of that international movement, which is generally much lower than the mobility within a particular country. There's been this exponential increase we've been talking about in terms of global mobility, and also I'm going to talk about Indonesia a bit here. It's one of the world's major reservoirs of migrant workers, both internally within migration in the islands as well as internationally. Much of it's between Indonesia and Malaysia, neighbouring country, which is relatively legal and illegal migration, but clearly Indonesia has a huge pool of migrants, of about, I don't know what the current figures, 240 or 50 million persons. So whatever we're looking at in mobility, it's relatively low to many other countries. If you take out China and India, it's one of the biggest Asian countries. So public health approaches to address migrant health and the host community, which is this is from a WHO report, the World Health Organization. They're concerned about some of the migrant mobility and its impact on public health and impact on the migrants themselves. They're looking from the aspect of to avoid disparities in health status, and particularly in access to health services between migrants and non-migrants in particularly low and middle income countries. To ensure migrants' health rights by limiting discrimination or stigmatisation. And we were talking about a lack of health rights, lack of human rights in a lot of the contexts yesterday. To reduce excess mortality and morbidity amongst migrant populations, particularly in situations of forced migration, particularly refugees resulting from disasters or conflict. Do you know what morbidity is? Morbidity, what does morbidity mean? Sorry?
Death.
No, mortality means death. Sorry? Sickness, infirmity, inability to, in other words, you've got some sort of disability or ill health which is actually probably chronic disease leading ultimately maybe to death, but clearly morbidity has been increasing amongst populations with population ageing. And to minimise the negative impact of the migration on migrants' health outcomes, particularly those more vulnerable to health risks, potential hazards, greater stress from displacement and adaptation to new environments. So there's recognition that these things are going on, and particularly recognition in the last few years that wasn't really very relevant before. So destination factors in migrant health, we look at new diseases and lack of resistance. Maybe the migrants moving to these places have no resistance to particular diseases, or lack of sanitary conditions sometimes in areas that people have become immune to, but new arrivals aren't as well prepared. Alienation, which means mental diseases, loneliness, lack of family support, etc. Or just a new environment that they're being ostracised in. Different service provision levels, or not knowing how to access or what you need to access or how you actually get health or other services. That lack of access is important. Maybe you just can't actually afford it. Maybe you can't actually access it because of your status or some other problem. An elevated sometimes risk of injury, particularly if you're a construction worker or someone else that has come in to do relatively low paid jobs. Now I'm going to talk about HIV AIDS, and just as so that we're all on the same page, I'm going to just make sure you know exactly. I'm not doubting you don't know, but I'm just going to put you all on the same page. So AIDS is acquired immunodeficiency syndrome. It's caused by HIV virus. You'd have a HIV virus and never end up with AIDS, but you basically have to be infected with HIV to actually finally get AIDS, and it's mainly AIDS that will then lead to your death. However, there's other ways. If you've got a HIV virus, that you can be co-infected with TB or hepatitis or some other nice disease that you actually then is put down as what you've actually died from, because it actually lowers your immune response. It spreads through fluids, blood, semen, vaginal secretions and breast milk, and it was only very late in its evolution, if you like, and its recognition that babies were dying, and they decided yes, they could be mixing of blood at birth, but this could also, it was transmitted in breast milk from people that were, or women that were HIV positive. Most common transmission is unprotected sexual intercourse with a HIV partner, and unfortunately women are more susceptible because their biology than is the other way around. Others infected have been initially through blood transfusions until there was very much screening of bloods, particularly in China. A lot of the initial cases were because of infected blood that was very much responsible for the spread of that disease. Contaminated needles, syringes, skin piercing equipment that hasn't been sterilised, any of them. That mother-to-child transmission was not first recognised through pregnancy, birth and breastfeeding. So I'll talk a minute about how this spread has happened at different stages in different countries and different regions. It's a fragile virus, which is one good thing about it. Can't survive long outside body's fluids, nor penetrate unbroken skin. So that's why if you get damaged in an accident and you're bleeding and someone has to look after you, or a footballer, a soccer player on the ground gets taken off because he's a blood rule, because there's potential risk that if he's bleeding for treatment, that clearly those rules are now in place. People living with HIV AIDS by region, it's just HIV. You can see by this graph that sub-Saharan Africa, 2/3 the cases, this 2007 hasn't shifted much, this proportional shift. North Africa, Middle East was very low, but that's been going up recently. Southeast and South Asia, South and Southeast Asia, about 12. Oceania, 1%. Latin America, about 5. Caribbean, very small. Eastern Europe and Central Asia was a worry and was increasing mid-2000s. And Western Europe and North America, about 4%. So you can see that HIV distribution much, much larger in sub-Saharan Africa than the rest of the world. updated 2014. Number of people living with HIV, roughly 37 million. It's average. It's a very rubbery figure, like some of these figures always are, and we estimate it to be an underestimation of the real extent. Because a lot of cases aren't notified. Also, a lot of people, they claim 50% of HIV cases potentially could die without not knowing they have the disease. So let's say the figure is much larger than that. 34 odd million adults, 17% of which are women, so that's roughly half. And children, 2.6 million less than 15 years. Newly infected cases, and that's what they've been watching with the hope with new treatment like antiretroviral treatments that those numbers have been reduced and they are decreasing. And so a total of 2 million in 2014, again 1.8 million adults and 220,000 children. And in all those cases they're average and they're estimates, so we don't really know the extent, but if we just take them as guidelines, we can say roughly things are improving, but not to the extent that some people might have estimated by now. AIDS deaths, and that's obviously the culmination of the HIV virus, 1.2 million on average, 10 million adults and 150,000 children. Again, why is that such an underestimate? Because a lot of deaths actually aren't recorded as AIDS. They're probably going to be recorded as all the things that could affect your immune system, like susceptibility to pneumonia is often one that's put down, and actually the underlying reason has been you've had HIV for a long time, which has developed into AIDS. TB, it's very hard to sometimes diagnose a co-infection, and TB is one of the most rampant ones at the moment, which is becoming antibiotic resistant as well. And so if your immune system's damaged, and the other one is hepatitis as a co-infection, which hepatitis C, and it damages your liver, so it probably go down as liver failure ultimately. So why do you think people don't want their deaths recorded as AIDS? If they have a say in it, or the doctors or the family don't want it recorded as AIDS.
It's because of the stigma.
Stigma. Very much a stigma attached to the disease and talking about it. And whilst STDs, sexually transmitted diseases generally, gonorrhea and that have been on, and syphilis have actually been on the rise again, and that all recorded, must be recorded. No one really wants to talk about HIV, AIDS, somehow or other has had a really stigma about it. It was initially seen as a disease of a few, like homosexuals and whatever, and that's sort of carried on. And it was only Nelson Mandela in Africa in particular, when he was president, one of his sons died of AIDS, and he was out saying he died of AIDS, and people went, oh, he shouldn't be saying that, because really people didn't want that sort of message out there, or people didn't want to actually say. So that's why I'm saying those deaths are probably an underestimate of the extent of what the outcomes of HIV actually are, because they can lead to those co-infections, and people would rather say my son died of pneumonia or TB than they would of HIV/AIDS. Anyway, so that's one of the problems of getting data that I guess really represents the extent of the problem. These are the actual and projected numbers of people receiving antiretroviral therapy in low and middle income countries, again by the WHO regions, World Health Organization regions, and in high income countries. And the blue are basically high income countries. So most people in high-income countries, relatively smaller numbers, but are getting treatment. And that was the new 5 years or so ago. That was really the big push antiretroviral, but again, it's new, so no one knew its long-term impact, but it has basically kept a lot of HIV people from developing AIDS. But I saw a report the other day that looks as if that's not all good news. It seems to plateau and it seems to be dropping out again. The real problem is it's expensive and not all countries can afford it and not all persons within countries can access it. This big swath here is African region, and that's not, and these are numbers, and clearly that's where the bulk of the cases are, so that's where the bulk of the treatment is. But as a proportion, it's a relatively low proportion. So you won't be able to see these, but for example, African region, it says about 37% are receiving that treatment, access to it. The Americas through here is about 44% on average. The stripe is North America, high-income countries like Australia, they are much more likely to have up to 75%, 80, 90% receiving treatment. Then the poorer areas, this blue is Eastern Europe basically, 22%, very low. The striped again is Europe, that's high income. And about 37% in our Western Pacific region of the Western Pacific includes all those places. So it's very variable, but on average about 11.7 million, 36% are receiving treatment for HIV. That's new. Initially they didn't have this treatment, but we still don't know its long-term effect or how long it can maintain that disease. So HIV in Africa, high prevalence and not universal access to those antiviral treatment, and therefore is continuing transmission through the country. It's important to look at the context and the type of mobility. Again, very highly mobile groups and workers in cities going back to country areas, etc., will convey much more risk, I guess you should be saying, than others. So risks associated with mobility acts through some of the proximate determinants, like, for example, their access to other goods, what types of patterns of employment they basically have. It transfers back to women left in villages by migrants, and they're especially at high risk because husbands return to the villages, or return from the cities, or return from another country where they've been working, and can infect unsuspecting women or partners, wives, whatever, within that other context. I'll show you how that works in a minute. Again, that's just adults and children estimated to be living with HIV, and clearly our red is Africa. Yellow, we scrape out as Western Pacific, but we're linked here. But clearly Africa is a standout case. Europe, in particular, the lowest is Eastern Mediterranean, and there's a reason for some of that as well. Deaths, it's interesting, Africa stands out in the deaths. You probably can't really see the distinction. Deaths are much higher also from AIDS in Africa, basically in low-income countries. The higher income countries, people have access, or government provides access or helps in the affordability of treatment. So that's why deaths are much higher, and that's adults and children. The change in the annual number of new HIV infections, and that's what they've really been trying to watch, to see whether education campaigns are working, are highest in MENA, that's the Middle East and North Africa, which was generally been the lowest. North America has actually gone up, where Eastern Europe, Latin America, Asia Pacific and Sub-Saharan Africa has had quite big declines. That doesn't mean to say they're still not out there as having the most, but they have been declining, which is good, as seen as a turnaround in some of the campaigns, and not just education but clearly treatment campaigns. This is just South Africa, a demographic implication, whereby South Africa population estimated to be in 2002, that's with AIDS, current projection, and projection without AIDS. So it's decimating, if you like, these groups here, young adult men, and more women actually dying than men, or infected anyway with AIDS. And clearly some of the narrowing obviously is children, young children dying, but the implication is clearly this group up here, grandparents often left looking after grandchildren, or the children are orphaned, which is a problem. And that's your working age population, so productivity, economic development also put on hold. So quite large problems, but another interesting thing is you would think fertility might have declined because of the messages, you can't have unprotected sex, but fertility is the highest in the world, so clearly that message is not deterring a lot of the sexual activity, is what I'm trying to say. I want to talk about Asia in particular, if we get time to get through this, or finish it next week. Risk behaviours of individuals or population groups are heavily influenced by the risk situations they're in. So it's risky behaviour rather than, and the situation you're in will put you in context of risk. Rapid transmission occurs through commercial sex and intravenous drug use, but the slower transmission, and that's what's been slow coming in some country, occurs through the casual and regular sex with partners often unsuspecting of the behaviour of the other half of the partnership. And for some specific groups are vulnerable to HIV/AIDS because of their work situations, living conditions and other risk situations. It can be in transport, fishermen, obviously sex and entertainment workers, but also include uniform personnel, state officials and migrant workers that are out on contracts or come and go and living separate from family basically. So for some of the region diversity in Asia, they basically haven't all come to this epidemic and the stages of the epidemic at the same time. So what we find is distinct onset and the severity of it, and some of them have reached their severe stage, fortunately, where there is some now treatment available. Thailand, Cambodia and Myanmar were basically mid to late 80s. Vietnam, Indonesia and some provinces in China, later, mid to late 90s. Laos and Philippines still have relatively low HIV prevalence, and people have been looking at some of these differences, trying to understand exactly why you get such disparities between countries. Sometimes you'd expect to have relatively similar conditions. Vietnam was one of the first countries in 2006, and some of the reason for that diversity is some countries just would not recognise they had a problem relating to HIV/AIDS. So it was culturally a no-no. No, it was just Westerners and it was travellers, and it wasn't anything to do with them, or it was sex workers servicing the travellers and tourists and whatever. And clearly, as long as we concentrated on those groups, we weren't going to have a problem. Vietnam, amongst the Asian countries, this report recognises for the first time Vietnam has come into the world and opened its eyes and looked at its cases that were rapidly rising by 2005, and looked at the the challenge and how do we actually deal with it. And the concept I want to take from that report is, I think, useful for you to understand why there's different stages amongst these countries and why it spreads or not. So it says Vietnam is still at early stages of the epidemic. HIV spreads from the high-risk groups, such as sex workers, to the bridge population, such as their clients. Other bridge populations include the partners of the sex workers, injecting drug users and other people who practice risky behaviour. So truck drivers, etc. Those living with HIV may experience discrimination. HIV itself does not discriminate. In Vietnam, the rising number of cases amongst pregnant women and their infants provides evidence that HIV is spreading to the general population. So they recognise, yes, okay, we shouldn't just concentrate on our high-risk groups like our needle and syringe sharing drug users, sex workers, men who have sex with men. But clearly these groups here are the unsuspecting, and clearly, if without protection or knowledge, and are the clients of the sex workers, partners of the person who have practiced high-risk sort of behaviours when they've been away working, migrants, mobile population, truck drivers, etc. When they said it's then spread to the general population, we have married women, babies and children, youth and men. Clearly, that group at the end was not recognised for a long time as being at risk. So the education campaigns weren't. And even in this report, when they asked women, were they at risk of contracting HIV/AIDS, 75% said, oh, no, we couldn't. 20% said, or maybe, I think 1% or 2% basically said they had sort of moderate to high risk. So again, that recognition amongst the other population had to be attacked if you actually want to actually try to control the disease. Migrant workers, some of these high-risk groups, are separated often from spouses for extended periods of time and may seek the services of sex workers. Commonly young adults, males, who are the most likely to seek sex workers and are earning sufficient cash to afford such services. And that's important. Once they have enough money, they can actually afford this as a service. Sex industry highly active in migrant worker destinations, and even the employers are often involved in encouraging the supply of those sex services. So to encourage people to go to outer islands of Indonesia somewhere in isolation, they actually also fund sex workers who then become migrants themselves, so workers in other destinations. They are removed from traditional constraints on behaviour which would prevail at home or in home communities or within their household generally, so therefore they're greatly at risk. The connection between mobility is really associated with movement, disruption of their cultural ties, etc., and removal from social constraints that might be applied at community levels, particularly in villages. Prolonged separation from partners and family. A lot of the contract workers, for example, go for 2 years and don't see families for 2 years. Existence of survival sex, marginalisation in those communities, and so to get over their depression or whatever. A sex industry development, again, that grows in all these migrant communities. Living conditions in destination might also be a prerequisite to actually getting sexual diseases, the expansion of these mobile occupations with development generally, and migrant marginality, particularly in areas that are not being accepted, or maybe they're illegal migrants, so they're not actually having access to full protection in some of those communities. It's just a theoretical framework where we have socioeconomic marginalisation, spatial isolation of migrants. We have diminished social control, removal from community norms. We have higher risk of behaviours, intravenous drug use could go together with commercial sex. We have other isolation geographical factors. We have pre-migration selectivity, individual factors, maybe the most adventurous, and singles go, or singles or otherwise. And we have this greater risk of both STDs, HIV infection and AIDS. The workers may become infected and spread it to their home communities when they return. And they're very unsuspecting communities. Infected workers may also pass the infection on to the sex workers, who in turn will pass it on to other clients and to their own communities, because they're often out of their communities as well. Workers often take the infection to other work locations where they pass it on to a new group of sex workers. That's the migrant workers. The sex workers themselves tend to work in a number of locations, so they also spread the disease to new areas as well. And there's a study done that tracks some sex workers, the spread of HIV through the islands of Indonesia. Quite interesting, just how quickly it spread, and someone had the nous to start tracking both migrant workers and the sex workers, where they lived, and see how it went back to particular communities that are often very much linked to certain work locations. That's just a diagram just really basically seeing the interconnections and relatively quick interconnections between commercial sex workers, customers, new workplaces and home areas. So potentially, so if the government is actually concentrating on certain areas of surveillance, are always these hotspots, not those home communities they didn't really recognise. Increased mobility. The greatest increase has been in non-permanent mobility, so it's this temporary migration and links that have really been responsible for some more of the rapid distribution anyway. Increased international movement through internal movement is more dominant. Flows are dominated by young men and women, and most economic migrants move without family, or the family members might join them later. Remember, our contract workers generally don't have family with them. Hotspots. So these hotspots were the main focus and have been the main focus of attention, particularly in Indonesia. They're outside cities. They emerged from a convergence of mobile populations and the rise of entertainment and sex establishments and unsafe sex, particularly in those locations. So they were seen as, if we tackle that, provide condoms, etc., we'll tackle the problem. Many ports, truck stops, towns, border locations fit the definition, and hence HIV intervention projects were levelled at them. Hotspots, risk situations where people are aware of the risk, and some cross-border migrants really might not be aware of some of the risks of HIV, and until recently only the hotspots targeted in surveillance efforts to reduce the risk and prevalence of HIV. Factors emerging amongst our overseas contract workers. They have done a survey of some of those overseas contract workers and seen those separated from families, often living in barracks, together in shared sort of accommodation, an easy target for sex industry workers, often in very isolated areas. They're usually away for 2 years or more, and young women are also often in very vulnerable situations, and it was found in some of those overseas contract workers, they were actually getting extra money on the side in some of those destinations they went to, which was interesting. And also there's an undocumented movement also that clearly is operating within these areas. So key issues: Indonesia has high and increasing levels of mobility, especially the movement of singles and unaccompanied married people that move frequently to Malaysia, Singapore, legally and illegally for lots of labour reasons and jobs. Population mobility is not necessarily associated with HIV infection. There tends to be a type of mobility, whether it's non-permanent without certain family members, and the context and the risk behaviour. Also, poor access to health and education programs. Skeldon 2000 argues that the mobility-HIV relationship is not so much migration that is important as the behaviour of migrants. It is a combination of migration and high-risk behaviour, unprotected sexual intercourse or sharing of needles by injecting drug users that is central. And sometimes they're engaged in both in terms of their risk behaviours. Mobility may put people into high-risk situations, therefore, and so intervention to control the epidemic through the control of human movement is unlikely to succeed. So in other words, it's not migration per se or mobility, it's behaviour of those people taking part in those sorts of activities. Now Australia, just quickly, some 27,150 people were living with HIV in Australia in 2014. Per capita rate AIDS diagnosis in Australia was 5 times higher amongst people born in countries in sub-Saharan Africa than among Australian-born. Number of newly diagnosed cases was relatively stable, around 1,000, and mostly men, 90% men. HIV notifications by age. This graph is the males are the blue, and it's showing clearly 20 to 29-year-olds, 30 to 39-year-olds, 40 to 49-year-olds, and predominantly males, females of the same age group, but very, very much lower numbers than the men involved. And that's also rate of diagnosis by country of birth, and clearly it was linked to some extent 2004, 2008, 2009, 13. The red and the blues highest amongst sub-Saharan African migrants, and lots of groups get screened, but clearly refugee groups were high amongst that group, and also South Central American, where that's risen recently, where HIV was higher, and also North America. Asia was relatively low though, and Australia overall was relatively low. Okay, in conclusion, so yes, Australia does have the problem, and is it linked to mobility? Not so much as what I've just been talking about, but there are indicators there that migrants obviously are a higher risk group, international migrants and others. In conclusion, we need to recognise the impact of migration on the health of migrants at destination and origin, given high levels of permanent and non-permanent movement internationally and internally within these countries. So all the things I've said applies to people leaving villages, going to the city, circulating around, but that can be extended to outside the country as well. We need to evaluate and monitor the spread of HIV with its direct links to migration, and educate potential migrants and non-migrants on risk. Those non-migrants are often partners or others aren't suspecting at home when migrants actually return. We need to guarantee antiretroviral treatment can be assessed and afforded by all who succumb at the very earliest stages of infection to ensure survival. The problem is people don't like being tested, and so they might not be tested to a very much later stage, and it's much more difficult for the antiretroviral drugs to work at that stage. But as long as there's stigma associated with, and you lose your job or you get deported, clearly people aren't going to be racing in to get themselves tested at an early stage. And because the symptoms aren't often severe, can be, even if you get tested, I think it's 12 weeks before you know the result. So it's a very long maturing sort of virus, so it's not, so it can get a hold, I'm starting to say, before any treatment or any intervention actually occurs. Okay, so I'm not saying migration causes HIV. I'm trying to say there's links